Yeah, I'll start. I think that is actually the core of this, of a lot of the issues that we were talking about just a moment ago in regard to misinformation and disinformation. I don't think in public health we've done a very good job historically of creating partnerships that are based on relationship. I think we tend to go in and think strategically about partnerships in local communities to get the things done we want to get done, and not always listening to communities about the partnerships that also address and respect the priorities of those local communities and the people in those local communities. And so a lot of what we are learning the hard way in response to this pandemic is in relation to working on the ground in local communities. We don't have the infrastructure built that represents holistic, sustained, mutual partnerships that where people come to the table in equal measure and as equal partners. Instead, we've got this history in public health of coming to different sectors, and we periodically come to the faith sector to conduct our community outreach or our community-based participatory research.
Right.
And communities get tired of that. They get tired of being treated as subjects for research. They get tired of public health officials showing up around a topic that they're funded to work on, but not necessarily addressing some of the broader kind of structural, endemic, sustained structures in American society that create health disparities in the first place and that contribute to inequities across the social sphere, including within health. And so what we are having to learn, and we're learning it the hard way in regard to COVID, and I hope we are learning it, I'm still not sure we are, is that we've got to be much more holistic and comprehensive in thinking about what partnerships look like. And we've got to be much more egalitarian at coming to the table, not as experts to tell communities what it is they need to do to implement the things we've studied, but to recognize that the knowledge and wisdom of communities is the essential starting block and starting point for all kinds of issues, COVID and other issues as well. And in time, that can build trust, but it won't be built immediately. And we've got to start demonstrating those kinds of qualities and characteristics and commitments in order to begin that process of building.
I'll second that and take it a little further. You're absolutely right, John. Part of the issue is that disparities have been muted and ignored for decades. The disparity between people of color, or even if you look at rural and urban, and many of us, have churches that we shepherd that are in rural areas. If you look at the disparity in health outcomes in rural versus urban communities, Black and brown communities, those disparities have existed for decades. And so much of it is based on, and what John was alluding to, and I'll call it out, and many of us have heard now what are called the social determinants of health. Yes. And those are those aspects of how we live, how we work, how we pray, how we die, how, everything that we do. And it's all resourced, and it's all based on disproportionate resources. And so if you don't have good access to health care, you're going to have a poor health outcome. If you don't have good access to education, employment, you're going to have a poor outcome. And so we need to bring infrastructure. And that's one of the things I'm glad to hear that John is doing at Emory, that we're doing at Wellstar, is to really think more holistically. That ecosystem needs to include the neighborhood. It needs to include education. It needs to include employment. It needs to include transportation. It needs to include food. All of those are meaningful drivers of health. And that's why these disparities have existed for so long. We don't need another commission to look at why these disparities exist. We need to have meaningful conversations and convene and collaborate the right partners to the table to move things forward.
Thank you so much, Dr. Hines. Dr. Akintobi, do you want to come into this conversation?
Well, I wanted our panelists to take center stage, and they've only called me back because what they're saying is resonating so well with the intent of Georgia's CEAL. You know, Dr. Hines, you really hit it, as well as you, Dr. Blevins, and all of you, and that is that community co-creation of the
Mhm.
solution is essential.
Yes.
We must have equal footing in determining not just the color of the furniture in terms of the response, but what is at the root of the issue. And Dr. Hines talked about the social determinants, and he alluded earlier to the political determinants of health. Uh, we're also clear based on the data that there is almost a direct overlay of the political color of a county or geography, the degree to which masking and other mitigation strategies are required, and COVID positivity and vaccination rates. There's something that we need to do about that. And it requires that not just researchers and clinicians are at the table, but local policy systems and faith influencers help us to not only understand, but to respond. So this is a really inspiring discussion, and I love the chat. So hopefully we can look at it and see some questions and comments that have come through.